I think we can get started.
Okay, sounds good.
Okay, great. Well, thank you everyone for registering and attending our webinar series for in breast cancer. We hope you are all healthy and keeping safe. And I know this is a little bit of a challenging time for all of us, but we hope everybody is staying well. My name is Cecilia, and I'm one of the board members of Elevate Cure Foundation. First and foremost, we wanted to thank Pfizer for their continued support for all of our education series that we provide to our patients and our healthcare community. A little bit about Elevate Cure Foundation. We support research, patient education, and patient charity programs. To learn more, our website is at elevatecure.org, and we hope that some of you would support some of our programs as well. So before we get started and before I introduce Dr. Gadi here, just a few housekeeping things. We will have a Q&A portion. On your screen, there should be a button that says Q&A, I think up at the top there, and you can submit your questions. If not, you can also send me your questions via email at connect@elevatecure.org. So we'll try that. Otherwise, I will unmute all of you, or you can raise your hands also, and I can have you ask your questions live. So with that, I'd like to introduce our key educator today. Dr. VK Gadi is medical director, professor and director for medical oncology at the University of Illinois, Chicago. He is an academic medical oncologist specializing in breast cancer and is regarded as a clinical expert with over 1,000 breast cancer patients under his care. He is also a noted educator. Dr. Gadi is a clinical investigator and translational researcher and a former medical editorial board for About.com and the New York Times Company, and former contributor to EverydayHealth.com. And with that, I will turn it over to Dr. Gadi.
Hi, everyone. It's good to have you here today. I'm going to share my screen here. I've not done one of these ASCO updates in this manner before, so this is going to be a learning experience for all of us, I believe. If I'm stumbling through it, please forgive me, but you can always stop me and ask me questions. I wanted to keep this informal, as like I run my own in-live person events. You know, people freely ask questions, and I want that to still be the same feel of this, if at all possible. I put these slides together mostly as a jumping point, and it's curated essentially from a handful of talks from ASCO 2020. I did one of these at the end of, in January, to cover San Antonio 2019, and every 6 months or so, I think it's reasonable to kind of revisit updates in the field. These are targeted towards discussions towards patients and caregivers and other providers. I'm happy to go into the weeds with anything to be more specific and scientific about matters, but it's really to update folks on what we as a community of medical oncologists and surgeons, et cetera, feel are the big things pushing the needle in the first 6 months of this year. So one other thing, ASCO this year was a virtual event. So we sat around on our computer screens for 4 days and listened to talks for as many as 10 hours a day, trying to capture all this information. It was curated for us, so it wasn't the same free-flowing conversation that we could have in a live person meeting, viewing posters and taking note of things we found interesting. We could certainly search for those things, but this is what was sort of fed to us as information. I'm going to share some of those things that the community of oncologists felt were important this year. So let's see if I can move. So just to step back a little bit, when we think about breast cancer, whether it's early stage or late stage, we try to lump the cancers into a few different characteristics based on what the pathologist tells us. And this is a decision tree that you can see. One of the first things we want to know is the hormone receptor status of the cancer. In other words, is this a cancer that is actually using estrogen and or other hormones to grow? So we check the estrogen receptor status. And if the status is positive, then we look at the HER2 status. And so then you become, if positive, a HER2 positive, ER positive cancer, if negative, an ER positive, HER2 negative cancer. So this is one grouping. And then if the ER status is negative, then we look at HER2. And if that's also negative, we have this group we call triple negative because both of the hormone receptors, estrogen and progesterone, are negative, but then they're also negative for HER2. And then if it's positive, this is one of those cancers we call HER2 enriched, where it's positive for HER2, but negative for the estrogen receptor. Biologically, these are very different cancers from each other. Biologically, there are many different subtypes here. There's many different subtypes here. There's probably a few subtypes here. But therapeutically, we tend to clump these into our clinical trials so that we can use similar tools to attack these cancers. And over time, as our understanding of the biology of these cancers becomes more refined, maybe we have more options and so forth. But for the purposes of this talk, I'm making this oversimplified lumping into three categories: triple negative, HER2 positive, and ER positive, but not HER2 positive. There's a lot of debate that could be held around whether or not that's a fair way to clump things, but for pragmatic purposes, that's how we're doing it today. So the next thing to understand is, what are the tools we have available to us as a medical oncologist? Well, I think all too familiar to many of us is chemotherapy. Put simply, these are the dumb medicines that kill things just because they're dividing fast. And they're effective for killing cancer, but they're also unfortunately effective at hurting normal cells that are also dividing somewhat fast. Things like the hair, skin, cells lining the GI tract, and that's why these toxicities happen: hair loss, nausea, vomiting, bone marrow suppression, etc. The other big category, at least in breast cancer, are these categories we call anti-hormones, and we'll review some of these. But for the most part in breast cancer, this means some way, some fashion, getting rid of estrogen. And then there's this novel group in the middle, which we call biologics, and there's a lot of different ways we can think about these. They're biologically inspired in the sense that they may be inhibitors that drug specific pathways. They could include biologic therapies we call immunotherapy. And now with an emerging sense of how the genome can be altered in a cancer, we're now making medicines that specifically target those genomic alterations. So again, a broad oversimplification, but these are the, roughly speaking, three tools available to us as we attack breast cancer. So with that in mind, let's get into the meat of this talk. So the first kind of updates will fall in the category of early stage breast cancer. So these are women who just learned they've had breast cancer. It's generally speaking operable, removable, treatable, and we expect and anticipate cures for most of these women. That's the definition of early stage breast cancer. The first category is going to be estrogen receptor positive, but negative for HER2. Now, in this group of cancers, there's a variety of different ways we can manage them. Some of these patients will need things like just anti-estrogen therapy after their surgery is done, but others may need chemotherapy and more aggressive medicines. And how we figure this out has always been a real challenge. And so the paradigm has been changing from one where we threw everything at every patient all the time to now saying and thoughtfully thinking who needs what and when, and who doesn't need what and when, and trying to figure out what those patients are. In the last few years, there's been a lot of excitement with what we call gene expression assays, which I'm going to explain to you in a minute. But one of the first updates we have is regarding one of these gene expression assays. So knowing that some people need chemotherapy, but the vast majority of early stage hormone positive breast cancers do not, we're stuck in this conundrum in trying to identify who they are. Historically, the way we did this was by looking at factors like how old is the woman, how big is the cancer, how many lymph nodes were involved. But then things moved away because we knew we were over-treating some of those women and under-treating others. And so these gene expression assays came to the forefront. Fundamentally, a gene expression assay looks at individual genes inside the cancer compared to other genes inside other cancers to look at which genes are turned way up and which ones are turned way down. And essentially every woman who has these tests performed for her has some sort of molecular portrait of that cancer with which you can make comparisons to other women who've also had that. The trials of these things generally looked at those portraits and then looked at the outcomes based on decisions that were made. And so the MINDAC study is one such study where they looked at this gene assay called MammaPrint. and prospectively, going forward in time, assigned women based on their clinical characteristics of their cancer and their mammoprint scoring to identify the optimum therapy for them. So this is just looking at the hormone positive, HER2 negative group of patients. Clinically, tumors were graded as grade 1, grade 2, or grade 3. And then they were characterized as whether or not they had nodes involved or not, and then the size of the cancer. So in general, the way I think about it to keep it straight in my head is 1, 2, 3, 3, 2, and 1. So if you have a grade 1 low risk cancer that is smaller than 3 centimeters, that's considered a low risk clinical diagnosis. And then if it's greater than that, it would be a high risk diagnosis because the tumor is large. Similarly, if there were nodes positive, there was a slight change in the algorithm as to who was considered low or high. On the other end of the spectrum, you have the high risk cancers, which don't have any nodes or even some nodes positive. Unless they're really, really tiny, these are always considered clinically high risk. And so as most oncologists, prior to the advent of these new gene expression tests, this is what we were doing for all our patients and saying, hey, even though it's a sort of 2 centimeter tumor, it's kind of a wimpy looking tumor underneath the microscope, you don't need chemotherapy because it looks low risk. And on the other end of the spectrum, you could say, hey, even though this is a small tumor, it has these ugly features associated with it, I think you need chemo. So that's how we were making these decisions. But then with the advent of these gene expression signatures, maybe we could do better and characterize patients not only on their clinical risk, but their gene signature risk. So the first of these studies, one of these studies that was published is the MINDAC trial published in the New England Journal a few years ago. And what they did at this ASCO 2020 was update their estimate of how these clinically high-risk tumors, but with genomic low-risk signatures, did without any chemotherapy. And for them, they considered it a failure if at 5 years, fewer than 92% of the patients had a recurrence. And in this patient population at 5 years, their estimate now is 95%. So in other words, 95 out of 100 people could skip chemotherapy, even though they had clinically high-risk tumor, but a low-risk genomic prediction. And this 93% here is what we call the lower bounds of our confidence that this is an actual number, and they needed that lower bound to exceed 92%, which it did. So in general, this is a positive study that even though you have an ugly looking tumor, at least based on what the pathologist is telling us, if the genomics suggests it's low risk, these are patients that don't need chemotherapy. But there was an additional finding that was happening, which is over time, as they monitor these patients beyond 5 years, in the period at which we don't think chemotherapy makes an impact anymore, looking at these patients now 8 years later, there was some interesting signals starting to emerge. So for example, the difference between not getting chemotherapy and getting chemotherapy was less than 1% at 5 years, but now it looks like it's starting to separate and is now 2.6%. And so this raises the concern, are we not treating some patients enough and then having them recur later? And when we looked more closely at this data, this is what emerged, that there was a difference between the young women who are using this test and the old women. So in the older women who are greater than 50, generally a group that was mostly characterized by having entered menopause, there was really no differences whether or not you got chemotherapy versus not. So at 5 years, that number was 95 and then 95.8. And then at 8 years, it was 90 and 90. So essentially the same number. But when you looked at the young women, even at 5 years, there was a little bit of a difference starting to emerge, and that difference got even more profound. So the question then became, is this really an effect of the chemotherapy, or is this an effect of some other phenomena that's happening? Because if the tumors themselves are still genomically low risk, they should, in theory, behave the same in both individuals. The big difference, though, is that women who have entered post-menopause are getting a form of anti-estrogen that blocks the production of the estrogen. Those are drugs we call aromatase inhibitors. However, in the really young women, the majority of these women receive tamoxifen, which is an estrogen receptor blocker. And one of the benefits of chemotherapy in young women is that it hurts the ovaries, it turns them off. And then when you turn them off, you're essentially forcing them into an early menopause. And with that forcing of early menopause, these women essentially now have become like this. And as a result, maybe that's why you're seeing these differences. And that's the hypothesis out there now, is that if we do skip chemotherapy in these early young women with early stage breast cancer with low risk features based on the genomic testing, maybe the compromise there is that we need to do a better job and optimize their anti-estrogen treatment by doing things like suppressing their ovaries with drugs and then blocking the production of estrogen. This is not an observation in isolation. This has also been something that's seen with a different test called the Oncotype DX test in patients who are young on the Taylor X study, a different trial that also people have hypothesized is the benefit of skipping chemotherapy and optimizing with the anti-estrogen instead. So that was probably the big update regarding early stage breast cancer in the first few years of management with regard to chemotherapy. There's another trial that was presented as well at this meeting called the IDEAL trial, and I'll show you what that is in just a minute, but it involved a different test called the Breast Cancer Index. So most of us know from many, many years and decades now of work that a minimum of 5 years of anti-estrogen therapy is beneficial in preventing of recurrence later on in life. But recurrence, as we now learn, can happen not just at 5 years, it can happen at 10, 15, 20, 25, 30, for decades afterwards. And the question then becomes is if we suppress estrogen some way for longer, can you prevent some of those recurrences? By and large, most of these trials have been mixed at best, and some of them have suggested very modest benefits, even if they have been positive. Right now, we have data showing that 5 years of tamoxifen followed by an additional 5 years could be beneficial. 5 years of tamoxifen followed by 5 years of an aromatase inhibitors could be beneficial. And then the majority of the studies that looked at an aromatase inhibitor that blocks estrogen production followed by an additional 5 years of aromatase inhibitors don't look very meaningful. So the question then becomes, is there a test that can tell us who really benefits from these interventions? And this is the test that seems to be answering that call. It's the Breast Cancer Index. It's another gene expression test, except the question is different. It's not a question of will you not benefit or benefit from chemo, but it's will you benefit from staying on anti-estrogen for longer. In the IDEAL trial, this is a trial that had roughly 1,800 patients on it. They were able to capture about 900 of the specimens and test them with the BCI test. And you can see some of those patients started on tamoxifen, some of them did tamoxifen and an AI, but some of them just did an AI by itself. And these patients were randomized in the original study to do another 2.5 to 5 years of extended therapy. And so these guys looked at whether or not you can make a distinguishing characteristic using this test between the 5 years and the 2.5 years. So from this study, they see that overall, if you look at all the 900 specimens they got, there was really no statistical difference between the 7.5 and the 10 years. And that's here, this p-value, which is a test of statistical significance, is greater than 0.05, which means theoretically it's not statistically significant, even though there is a modest improvement in the number of women who don't have a recurrence. However, when they looked at the low risk score of this BCI test, you can see there's no difference at all in the two groups. However, when you look at the high risk group, there's a difference of almost 10% between the two, suggesting that this test can now identify women who started an aromatase inhibitor in theory and would benefit from prolonging that for as many as 5 more years to get to 10 years of total therapy. This is now probably a very meaningful finding. It may change clinical practice, and there's additional studies that will be coming out looking at 5 years of an AI followed by 5 years more of an AI without this 2.5 kind of intermediate length duration, and that might be the most relevant for our patients. So I'll now move to early stage breast cancer and triple negative breast cancer. So these are the ones that don't make any of the receptors that we try to target in breast cancer. And there's one study that kind of met the challenge of being worthy of discussing at ASCO this year at the broad audience level, and that was this trial from China. And this is looking at a chemotherapy being added to standard therapy after all standard therapy is completed for a year of duration. So in this trial, they invited women with these characteristics. They randomized them so that half got observation and half got this drug called capecitabine, which is a chemotherapy, an oral chemotherapy that you take twice a day for 1 year in this trial. The standard way to use this is twice a day for 14 days and 7 days of a holiday, but at a higher dose. They tried a lower dose where they just took it all year long. And then they had a variety of different patient characteristics they looked at and stratified their analysis for. And in the end of the day, the patients were averaged about 46 years in age. The vast majority were lymph node negative. Tumors were generally large, between 2 and 5 centimeters in the majority of patients. And then you can see the stages, many of them were early stage, but the majority were stage 2 and above. And so their primary endpoint was to evaluate when women had their cancer come back. And if you look at 5 years from the date of randomization, the group that got no chemotherapy for an additional year, at 73% of them were free of disease, whereas it was 83 when you had the capecitabine treatment. So an improvement of 10%. This was statistically significant. Again, when you look at this p-value, we look at 0.05 as the cutoff, and this one is less than that. So this would mean this is a meaningful finding. They did take an early peek at whether or not women were simply living longer, not having had their disease come back. And you can see that there's a more modest difference here. It's only 5 percentage points. This may improve over time, and I suspect they'll continue to monitor this, but if it would not surprise me if this was an improvement. Now, to put this study in context, we knew from other studies that this capecitabine medicine might be helpful in triple negative. The problem is most of those studies invited lots of types of different cancers, and the triple negatives were only a small subset in those cancers. So even though it looked promising, they were what we call underpowered to make convincing arguments that this should be the standard for patients who had triple negative disease. I would argue now with this trial being published that it adds another healthy piece of evidence that maybe for our triple negative breast cancer patients who go through either surgery first or even have preoperative therapy with chemotherapy before they go to surgery, that we should strongly consider capecitabine in patients who are still at risk with this otherwise very aggressive type of breast cancer. And then lastly, in the early stage grouping, I wanted to talk about some innovations that we saw in HER2 positive disease. So HER2, to revisit this, is another receptor that we commonly look for in breast cancer. It's present on about 25% of breast cancers. And when it's there, it's like a really big gift for the cancer. It helps it grow faster and spread quickly. And in the old days, these women had some of the worst outcomes we would find with breast cancer. All of this changed because we were able to come up with some targeted biologic precise medicines against HER2. And now, thankfully, these women enjoy some of the best outcomes we see. In fact, I had one advocate who's a friend of mine who commented that at San Antonio this year, she had a little bit of HER2 envy because these women had so many new targeted agents available to them with really meaningful improvements in their outcomes. So this is going to look at 2 studies here that were presented at ASCO this year. The first is a study called Caitlin. And Caitlin was trying to make the tolerability of how we treat HER2 positive breast cancer better, but also to improve on our outcomes using a drug called trastuzumab emtansine. So trastuzumab, many of you will recognize, is what we call an antibody. It's an antibody that doesn't occur naturally in nature, whereas, when I get a cold and I need to fight it off, I make antibodies against it, and then the cold doesn't happen again. Well, trastuzumab was engineered from the ground up to not care about a virus or something, but instead to care about HER2. And when you inject it into the person, it finds the HER2 positive breast cancer cells, and we believe it invokes a really strong immune response against the cancer. TDM1, or trastuzumab emtansine, is a spin-off of this trastuzumab or Herceptin drug, where they attached physically a really potent chemotherapy to the trastuzumab, such that when the trastuzumab finds its way to the cancer cell, it enters the cancer cell and releases the chemotherapy from within and kills the cancer cell. Pertuzumab is another monoclonal antibody that binds on the outside of the cancer cell, and rather than invite an immune response, what it seems to do is it prevents the HER2 molecules from talking to its kissing cousins that then productively make signals to tell the cancer cells to grow. And the standard had been to combine pertuzumab and trastuzumab with a chemotherapy called Taxol. But here what they did is they exchanged out the trastuzumab and the Taxol with TDM1. And so this is the overall study design. People had surgery first. There were 1,800 patients. The vast majority of the patients, about 1,600 enrolled on the trial, had lymph nodes that were involved. So these are our high-risk patients. They had 3 or 4 cycles of classic adriamycin-containing chemotherapy. And then when they started the taxane portion of the chemotherapy in combination with trastuzumab and pertuzumab, half of those patients were randomized instead of the chemotherapy to get the TDM1 plus the pertuzumab. The study was designed to show that this was better than this. And here's what we saw. In the node positive group, which again was almost 1,660 of the patients on the study, the vast majority, like I said, the 2 lines don't diverge from each other. It didn't matter which one you got, you did the same. So certainly you couldn't argue that this was therapeutically more effective. In other words, it kept more people from having a recurrence of that. That was not the case. And at 3 years, the numbers were 94 and 93%. But what was interesting is that these targeted agents like trastuzumab and tansine, when compared to chemotherapy, tend to be associated with better well-being. And so you don't ask a doctor if his patient is well, you ask the patient if she feels well. And when we asked the patient, their patient-reported outcomes suggested that the TDM1 containing regimen was actually much better tolerated with lower declines in functioning and physical and other types of functioning. So one could argue, hey, you know, maybe both drugs work the same or both strategies work the same, but maybe we should be using this strategy instead. And this is open to debate because it does turn out on study that even though patients felt well, what the physicians were monitoring in terms of the toxicities we look for to things like the bone marrow and the heart and so forth, you know, we were more worried about this trastuzumab and tansine arm causing more harm than the THP. So in the end, the recommendation was this is not a strategy we should use. But it's interesting that this is the second trial now of trastuzumab and tansine in early stage breast cancer where the patients seem to be happy, but the doctors weren't. So we'll see how all of this rolls up at the end of the day. The last study in the early stage breast cancer setting I wanted to cover was this one called the TRAIN2 study. And the goal here was to see if we could get rid of anthracycline chemotherapy in the care of HER2 positive disease. For years, we've known that anthracycline chemotherapies seem to be particularly effective in HER2 positive disease, and it's been hard to get rid of them. Anthracyclines are very effective chemotherapies. They're used in a variety of different cancers, and the one that we primarily use in breast cancer is doxorubicin, also known as adriamycin, or in Europe, they use a drug called epirubicin. And these drugs have been a mainstay. But the 2 major problems with this drug, other than the short-term toxicities, is that about 2 to 5% of women can develop long-term cardiac injury, which can lead them to have heart failure later in life. And then an even smaller proportion of patients can develop leukemia as a result of having been on this drug. So we've always been interested in seeing if we can get rid of this drug in all of our cancer care, but in particular in the HER2 positive cancer patients. So this trial formally evaluated this by doing a combination of paclitaxel, Taxol chemotherapy, with trastuzumab and pertuzumab and carboplatin chemotherapy. So this is, in the United States, we call this TCHP, but they call it different things in other places. Normally, patients would get an anthracycline, in this case, FEC, with E being epirubicin, Taxol and pertuzumab, followed by 6 cycles of this regimen. But here they just dropped this and included this, and they included patients with, generally speaking, larger amounts of disease. And then their main goal was to see how many patients, when they got to surgery, when they had done this therapy before surgery, achieved something called a PCR, a pathologic complete response. In other words, you get to surgery and there is no cancer left and there's nothing in the lymph nodes left. They also looked at things like toxicity and so forth. And here's what they saw on the original TRAIN2 study, which is that roughly 68% and 67% of the patients in both groups had no cancer remaining in their nose. So that was already published and known. So, oops. I'm sorry, I've lost a slide here. So the update at this meeting was that indeed the toxicities from this arm could be potentially spared by not having this chemotherapy involved in this regimen. I apologize, they presented long-term outcomes and I lost that slide apparently. So when we summarize from ASCO of this year, whoops, another typo, 2020 early stage breast cancer, In the ER-positive non-HER2 category, women less than 50 may benefit from chemo even when genomic scores are low. But the question is it really because of better ovarian function suppression? That's from the MINDX study. And then the second thing that we saw was that extended aromatase inhibitor therapy may benefit women with high scores on the BCI test, and that's from the IDEAL study. And I think more of this is going to be coming in the very near future. In the triple negative breast cancer, I think we've secured capecitabine as an oral agent given for a period of a year in many triple negative breast cancer patients as a standard of care. This is now the second, maybe third study that's validated this finding. And then in HER2 positive space, TDM1 misses the mark again in early stage disease, but the question is, again, question mark. It seems that patients seem happy, but the doctors are seeing toxicities that make them uncomfortable, and all while delivering equivalent outcomes. And then, can anthracycline chemotherapy be spared? The update on TRAIN2 suggests that this may still be the case. So switching over to metastatic cancer, I'm going to focus on the cancers in the same way, grouping them as estrogen receptor positive and HER2 negative. Actually, before I do that, I'm going to pause here. I'm going to stop sharing my screen and see if anybody has any questions on the early stage stuff. Okay, I don't see any hands going up, so I'm going to keep going, but please feel free to interrupt me if you have a question. So in the metastatic disease setting, we're looking again at estrogen receptor positive but HER2 negative disease. So to backstep a little bit, how we target hormone positive breast cancers has evolved dramatically over the last few years. And questions really have now come up about which drug comes first, which one comes second, and how do we figure all this out? So let me just go over the tools really quickly. So we first learned that compared to tamoxifen, an aromatase inhibitor, which decreases estrogen production, is better than tamoxifen. We then learned from a variety of studies that were kind of ill-designed initially, but eventually came to the answer, which is that if you use an estrogen receptor destroyer, like the drug fulvestrant, that seems to be better than an aromatase inhibitor. So I've got a question about the Palace and Monarchy press releases regarding in the adjuvant setting. So I am going to respond to this really quickly. I have not read those press releases just yet, but we do know that there are actually there are a number of large clinical trials on using these drugs called the CDK4/6 inhibitors, which I'm about to review, in early stage breast cancer. So I'll address that in just a minute. So when we look at the sequence of anti-estrogen therapy, the CDK4/6 inhibitor plus an AI or fulvestrant seems to be better than either the AI or the fulvestrant. And there's a number of studies showing this. So there was a trial that was presented at this meeting called Parsifal, which asked the question, when you have a CDK4/6 inhibitor, in this case that was the drug palbociclib, is it better to combine it with an AI first or with fulvestrant first? So this is the design of this particular study. Again, patients who had no previous therapy for advanced estrogen receptor positive metastatic breast cancer. They could be post or premenopausal, and if premenopausal, they had to have suppression of the ovaries. And there was some other criteria that I'll skip for now, but these are generally what we were looking at. The stratifications were looking at whether or not patients had new disease that was brand new metastatic or if it was recurrent, and then whether or not there were major organs involved. They randomized patients to either, both groups got palbociclib, but half got the fulvestrant medicine, the other half got letrozole, and then they monitored these patients to see when the disease might have gotten worse. And this is the overall finding. So the prediction was that this fulvestrant palbociclib might actually be better than letrozole plus the palbociclib. But here we see, if anything, the opposite might be true. Truth be told, statistically, these two lines are not different from each other. And that's what we see here. and there's no statistical significance to this p-value. It's well over 0.05. So there was, quote, no difference. However, when you looked at Parsifal more carefully and based on whether or not patients had previously seen an aromatase inhibitor in their early stage breast cancer therapy, there was a finding that seemed to emerge that the fulvestrant was better than the letrozole. And so in our practice, we often wonder and worry about this. It turns out if you've been on an aromatase inhibitor for 5 years, and then time goes by and then you have a recurrence, will the aromatase inhibitor be the best choice for that patient? Over that course of that therapy, there are mutations that occur in the cancer, one in particular to the estrogen receptor called an ESR1 activating mutation. If those mutations happen, even when you starve the cancer of estrogen, they seem to be behaving as if there's estrogen present. And so the aromatase inhibitors may not work as well. Whereas if you destroy the estrogen receptor, even if there's a mutation present, then the cancer stops growing. And that's what fulvestrant does. So even though the overall study, when you looked at both groups, suggested no difference in which drug was given first, we do observe a roughly 14% improvement with a kind of what looks like a big difference in when the cancer first gets worse after starting, depending on whether or not you got fulvestrant or letrozole. So that's a little pearl that was in this Parsifal study. So to answer that question about the CDK4/6 inhibitors, so palbociclib is one of these drugs, and there's two others on the market in the United States. And these drugs fundamentally work by blocking a pathway that cancer cells co-opt to help themselves grow. So even though you're starving them of estrogen in some way, they've got this other thing that's driving them. And if you can somehow block that with these drugs, maybe force them to care about estrogen, but then take the estrogen away, these drugs become very helpful. And that's what we learned from the metastatic setting. Fortunately, in the metastatic setting, these drugs have been, generally speaking, well tolerated. And when we see a well-tolerated, very effective medicine, our next question is, can we use these drugs in early stage breast cancer and prevent patients from having recurrences down the road? So there are a number of studies that are now going to start reporting out, looking at the CDK4/6 in early stage breast cancer. And I look forward to that data and especially being able to digest it when it officially comes out. So in the metastatic setting, the next tumor classification are the triple negative breast cancers. And here, the main innovation that's been going on, there's been a few, and as of last ASCO, there was one of these antibody drug conjugates, sort of like the TDM1 medicine we talked about for HER2 disease, except for triple negative disease. It got just FDA approved. And then more recently, there have been these drugs that we've been evaluating called immune checkpoint inhibitors. These have been all the buzz in all of oncology and now are finding some inroads in breast cancer, specifically in the triple negative disease. Pembrolizumab is one of these drugs. So the checkpoint inhibitors work in the following manner. They somehow, as cancers are developing, one of the things that the cancer cells have to figure out is what to do with the immune system, because the immune system is there to get rid of them. And over time, during this evolutionary race that's going on between the immune system and the cancers stumble on ways to sort of say back off to the immune system. And they do these with molecules we call checkpoints. These checkpoints basically tell these immune cells that are coming into the tumor's neighborhood saying, go away, there's no party here. And the immune system keeps marching on by, allowing the cancer to grow. What the checkpoint inhibitors do is they go into these cancers' little neighborhoods and take off the do not disturb signs, these checkpoints. And then once they're gone, the immune system strolls by and says, hey, there's something really awful going on in here. And they try to bust up the party, and that's how they work. These drugs are extremely effective in many diseases, but they've been a little bit hard to figure out how to utilize in breast cancer. When we use them by themselves, they seem to only push the needle just a little bit. But one thing we realized, especially in early stages of metastatic disease, if you combine these with chemotherapy, it seems to be more active. So the first drug to get approved for triple negative breast cancer in this manner was a drug called atezolizumab, and that's a drug manufactured by Genentech. And that drug is combined with a chemotherapy called Abraxane. The idea there is that the Abraxane is given, it damages the cancer cells, they get really inflamed and angry, and then the immune system is better able to recognize that with the presence of a checkpoint inhibitor, and they synergize together and get rid of the cancer. The other drug, pembrolizumab, was studied in this study called Keynote 355, which is presented here. What they looked at is they looked, first of all, to see if the target, the checkpoint, is present. And then they handled patients who had advanced triple negative disease, and they excluded patients in this study without who had any involvement of the central nervous system, in other words, brain metastases. They randomized these patients to either get treatment of physician's choice chemotherapy plus pembrolizumab, or treatment of physician's choice plus a placebo, and then they looked to see how they did over time. They also stratified patients based on whether or not they had high level or even a modicum of expression of this PDL1 marker versus none, and then move forward from there. So in the overall group of patients on this trial, you'll see over time, many of them continue to recur, but there's this very modest point at which half the patients that recurred, that's different. So for the patients who got the pembrolizumab, it was 7.5 months, and it was 5.6 months. And that doesn't seem very exciting. It's only 1.9 months, and it was of modest statistical importance. But when they when they looked more carefully at the patients based on this marker of the checkpoint, patients who had a score of greater than 1 on this test that they used, of which 75% fell into that category versus the 25% that didn't. I'm sorry, versus the group that had that same characteristic but got placebo, you'll see that it's still only a 2-month difference, very similar to these numbers, but actually more statistically significant. And then when we looked at the patients who had much more robust expression of this, you can see those numbers really start to separate, 9.7 versus 5.6 months. And again, statistically significant. Only a third or so of the patients fell in this category. So it's starting to look like these drugs may work. They don't seem to work for everybody, but certainly when patients have good levels of expression of these markers, there seems to be a difference emerging. And then the last update I'm going to give you from ASCO 2020 was with HER2 positive disease. And then specifically, there was an important update given about brain metastases. So I'll just back up and say brain metastases are very, very common in breast cancer. And the longer you've been fighting your breast cancer, the more likely a brain metastasis can happen. In HER2 positive disease in particular, roughly half the patients who develop metastatic disease will at some point be diagnosed with a brain metastases. That is unfortunately a very high number. And moreover, unlike some disease like hormone positive breast cancers, which seem to attack a place like the bone first or some other organ, HER2 positive disease frequently finds its way to the bone very early in the process. So its characteristics of how it attacks the brain is very, very different than some of these other cancers. There's a term called HER2 tropism, meaning that the breast cancer has an affinity, a likelihood, a love of getting into the brain tissue. And so that's something that we're always vigilant against and for. Unfortunately, a lot of clinical trial development historically has excluded intentionally patients who have metastases in the brain. And that's because once a brain metastasis used to happen, patients often succumb to their disease very quickly. And the drug developers felt this wasn't a fair fight for their drugs because they couldn't show a difference when brain metastases were at play. So they often just excluded those patients. However, there was a drug called tucatinib that was being developed that was actually an inhibitor of HER2. And rather than like trastuzumab, which blocks HER2 at the outside of the cancer cell, tucatinib is one of these smaller molecules that can enter the inside of the cancer cell and block the actual enzyme from the inside of the cancer cell. And so it works very differently than trastuzumab, pertuzumab, TDM1. And because it was a small molecule, it looked like, and we knew it was crossing across the blood-brain barrier and entering the central nervous system where in theory it could be active. So the folks who designed the HER2 CLIMB study made the courageous, in my view, jump and leap to saying, we don't care where your disease is, even if it's in the brain, we invite you to be on the study because we're going to show that maybe this drug can make a difference even in the highest risk patients. So this is the HER2 CLIMB trial. It was presented by my colleague Reshma Murthy at San Antonio in 2019, and I've reviewed this before, but essentially they had patients with metastatic breast cancer who'd seen at least a few cancer therapies in the metastatic setting. If you had a not if you had a brain, everybody had a brain, but they also had a brain MRI at baseline. I guess that, you know, maybe there was a few congressmen on the trial, and you know, whether or not they had a brain is not clear. But anyway, previously treated stable brain metastases were invited. In other words, if you'd had an intervention like surgery or radiation therapy, you could be invited. But then they also invited patients who had untreated brain metastases not needing immediate therapy, or previously treated progressing brain metastases not needing immediate local therapy, and looked at what happened with these patients on the study. At San Antonio, this is one of those studies that caused my friend HER2 envy, because this is such a dramatically improvement in outcomes between the two groups, the group that got to tucatinib and the placebo. However, at San Antonio this year, Nancy Lin from Harvard presented these findings, which is to look at the brain metastases specifically. And they looked at overall survival in brain metastases in all patients. And then they looked at overall survival benefit in patients with active brain metastases. So this is the hardest group to treat in oncology. And you can see in both groups, there was a dramatic improvement in the proportion of patients who were surviving with their brain metastases. And overall, the difference was 18 months to 12 months. And at the 12-month time point, the 50% line had been crossed for survival, but it was still well above 70% here. And similarly here, it was 72 and 41% in the active brain metastases. I know these numbers are still in some sense discouraging, but for many of us, this is our first demonstration that we can actually push the needle, and it arms us with more courage, I guess, to invite these folks onto trials and to use our newest medicines to continue to push this number out as far as we can. So just to summarize the metastatic presentations at ASCO this year, in the ER positive, not HER2 positive, an AI paired with a CDK4/6 inhibitor, as demonstrated in the Parsifal study, still seems to be the right first choice, although an argument could be made if a patient had seen an aromatase inhibitor in a prior line of therapy, that fulvestrant might be a reasonable first option. In the triple negative, similar to atezolizumab, pembrolizumab seems to be effective maybe in some of these PD-1 expressing tumors, PD-L1 expressing tumors. I didn't discuss it. There's unique toxicities associated with these drugs that we have to be on guard for. And the question there really is the price of the toxicities worth the modest improvements? And some would argue no. And so the search is on for more effective ways to identify the patients that will be the most likely to benefit, so that we can spare the vast majority of some of these really obnoxious toxicities that can happen with these drugs. And then in the HER2 positive setting, we feel really empowered now with the availability of tucatinib to challenge patients who even have brain metastases to improve their survival. So that's the last slide I had. I wanted to keep sufficient and ample time for discussion, and I can cede the floor back to Cease here. Let me stop sharing.
Yep.
And there's Cease. So happy to take questions. I hope that
Thank
was
you,
clear.
Dr. Gadi.
Yeah.
I actually allowed our attendees to be able to ask the questions live. So if any of you have any questions for Dr. Gadi, feel free to unmute and ask your question. No? Oh.
This thing about breast cancer.
Beverly or Kyungdong, do you have any questions?
No, not really.
Okay. Beverly, is there any, do you have any questions?
No, thanks. I think that was a mistake.
Oh, that's okay. That's all right. Anyone else?
I have a question. This is Dr. Gadi. So, Manpreet, I hate to put you on in the spotlight here, but you asked this really interesting question about the Palace study and the press release. I've not seen the data. I understand, there's some concern about futility, and I'm still hopeful there's a subset that benefits. But I guess, can you inform us a little bit about what the issue is, and then we can talk about that? I think you're still on mute, Manpreet, it looks like. There we go.
Go ahead, Manpreet.
Okay, well, it doesn't seem to be working. I'm not sure. Okay.
I think he had to dial back in.
Okay. Well, we can. There he is. I see his picture.
Yeah, there you go.
Okay. Are you able to hear me now?
Yeah, we are.
Yes.
Perfect.
Okay. All right. Well, the press release was, it came out in late May, early June from the PALAS study, which is the adjuvant study for breast cancer. The trial is not going to meet its endpoint. These are all-comer patients. That was a press release. And then the Monarch E press release was for the abemaciclib. This was the high-risk patients, and the endpoint was met. But no data has been shared beyond that. I just was wanting to get your thoughts on, using of CDK4/6 inhibitors in the adjuvant setting, as well as just your reaction to the press release.
Yeah, so I was vaguely familiar with the press release, and I had not seen any actual data, so I've been loath to speak about it because the devil's often in the details, as you know. Study design is everything, and if you take a big swing sometimes, you get burned, and maybe that's happened with PALAS, where if you take too many low-risk patients who really were going to have good outcomes and try to intensify their therapies with something like a CDK4/6 inhibitor, it's possible your trial doesn't meet your endpoint. That seems maybe what's happened there. But the Monarchy, they tended to focus on the slightly higher risk patient population, and they seem to have met it. But again, I have not seen this data, and whatever endpoints we're looking at are going to be very early. It is possible, PALAS being a much larger sort of inclusion group, that there may be subsets of patients who do look like they're going to benefit. We see this playing out in a few other places. You look at HER2 positive disease in particular, and you look at the use of the pertuzumab antibody drug in early stage breast cancer that's HER2 positive. And that study just eked out a modest improvement in survivability of the cancer, but they eked it out in really the highest risk patients, whereas the low risk patients were making it so the drug didn't look like it was working. So the lesson there is really to focus probably on, at least in your initial studies, on the highest risk patient population to see if you can push the needle there. That's my humble opinion, I guess. So it is fascinating. We'll see what the studies look like when they are actually presented at major meetings and the manuscripts come out, because I think the devil will be in the details. Okay.
Any other questions? Okay. Well, we also recorded the webinar, so we're going to send out an email with a link to the recording to all of you and to the other attendees, and we'll also post it and share it on our social media. Okay, so with that,
for organizing this, it's an amazing activity, and I'm proud to be part of it.
Yeah, fantastic. Thank you again, everyone, for attending, and this concludes our webinar.